we've got Dr. Suzanne Slonim. She's the medical director of the Fibroid Institute of Texas. She's also an author of some well-known books. She went to medical school at George Washington School of Medicine, did her residency at the Lahey Clinic of Boston in diagnostic radiology, and then did her fellowship at Stanford University in IR. Her clinical focus is treating uterine fibroids and uterine artery embolization.
I'm Suzanne Slonim. I'm an interventional radiologist in private practice in Dallas. I'm in an office-based lab, and my entire practice is dedicated to uterine artery embolization, dedicated to treating fibroids without surgery. What are fibroids? They are benign, smooth muscle tumors in the uterus. They're very, very common. They can be anywhere in the uterus. It's the intraluminal or submucosal fibroids that cause very heavy bleeding and clotting, but any of them can cause significant symptoms depending on where they are and what they're pressing against. The common fibroid symptoms are very heavy menstrual bleeding, cramping pain, urinary frequency, spotting, constipation, dyspareunia, bloating, back pain, infertility, among other things. Who gets fibroids? The answer is essentially everybody can get fibroids. About 50% of women will have fibroids by the age of 50, but they are a particularly bad problem in Black women. It's about 80% of Black women have fibroids, and it tends to be a much more difficult clinical problem for them. The treatment options, there are a lot of treatments for fibroids. Hormone treatments can help with heavy bleeding, and there's some new GnRH antagonists that are actually pretty effective in treating fibroids, but they can only be used for 2 years. Endometrial ablation can help with heavy bleeding sometimes, can be difficult in a woman who's got big fibroids. UFE, we're going to come back to that. Myomectomy, the removal of fibroids leaving the uterus in place. It's a technically difficult surgery to do. A lot of gynecologists don't offer it, but it is the procedure of choice for women who are trying to get pregnant. Hysterectomy is the definitive treatment and prevents the possibility of ever being troubled with fibroids or any other uterine problem in the future. The problem is that many, many women do not want their uterus removed or don't want surgery. Uterine fibroid embolization, the hero of this talk, to treat fibroids without surgery. Uterine fibroid embolization involves blocking the blood supply to the fibroids to cause them to die and shrink, and 90% of the time it takes care of all the symptoms. The way I do it, and it can be done femorally, but I do it radially. I catheterize the radial artery under fluoroscopic guidance. I pass the catheter down into the pelvis. The anatomy is such that you go common iliac, internal iliac, anterior division, and then the uterine arteries, usually the first branch of the anterior division of the internal iliac artery. Once the catheter is in the right place, we embolize with particles. The right place means particles are not going to go to the bladder or to the vagina or to the perineum or to the pelvic sidewall, just to the uterus. Now, this picture shows it going just to the fibroids. The particles are injected into the main uterine artery, but the fibroids are like a parasite sucking the blood, and so flow preferentially takes the particles to them. The particles we use are microcalibrated. They're sized to be the right size for the perivascular vessels around fibroids. They're FDA approved. They're very effective. So this is a woman, a 51-year-old woman with heavy bleeding and pelvic pain. And you see on this coronal MRI a very large fibroid in the uterus. You see where the iliac crests are. Notice that the uterus is coming up above the iliac crest. And on the angiogram, you see this very vascular mass. You'll see it fill in that corresponds very nicely to the mass seen on the MRI. And when we embolize this, down at the bottom, you see some flow going, reflux into other vessels, but here you see the flow is essentially stagnant in the uterine artery, which is what you want to get. The end point is to have a stagnant column of contrast for 5 to 10 heartbeats to make sure the fibroid is going to die. This is a 43-year-old Jehovah's Witness. She bleeds heavily 2 weeks out of every month. She also has pelvic pain, and when we look at her angiogram, you see, again, a beautiful correlation with a very vascular uterus, a very vascular mass. She has a few other fibroids in the uterus, And then after embolization, again, you have a stagnant column of contrast in the uterine artery. So what happens when we embolize? We expect about a 50% volume reduction in the uterus, volume reduction in the fibroids and in the uterus. So if you take a grapefruit and you shrink that 50% in volume, you're going to end up with an orange, not with a lime. Okay, that's very important for patients to understand that. But we know that symptom relief does not depend on volume reduction. It depends on the fibroid being dead, no longer sucking the blood. The fibroid's not under high pressure flow anymore. A live fibroid is hard like a solid rubber ball. A dead fibroid has a consistency more like toothpaste, doesn't press on the adjacent structures as much. This is a woman with a 6.5 centimeter fibroid. Notice how close the uterus is to the rectus muscle. Notice that the uterus is coming to the top of the sacrum. This is an enhanced scan. 4 months later, we see that the fibroid is not enhancing because it's dead. And that's all that's required to relieve the symptoms. The mass is still there, but you can see how much the fibroid has come down from the top of the sacrum and how much the uterus is retracted from the rectus muscle. This is a 50-year-old woman with heavy bleeding, pain, and trouble urinating, okay? And on her sagittal MRI, you see her uterus is retroverted. She's got a large anterior fibroid, which pushes the fundus posterior, which pushes the cervix anterior, which kinks the bladder at the urethra and makes it very difficult for her to initiate urination. I see this a lot in women with a retroverted uterus. She also has an intraluminal fibroid here, which is giving her the heavy bleeding. 3 months after the UFE, we see the fibroid has shrunk significantly. The fundus is no longer pushed posteriorly as much. The cervix then can move back a little bit, and her symptoms are relieved. You can see that the fibroid's not enhancing on the enhanced scan. This is just a great example, a sagittal and coronal view. I think this is the most shrinkage I've seen in one of my patients. This is the before, this is the after. You'd hardly believe that it's the same patient, but I promise you it is. The advantages of UFE are that there's virtually no blood loss. There's no incision, which is very important to a lot of women. The recovery time is much shorter than a myomectomy or hysterectomy. And a very important point is that all fibroids are treated at once. We're gonna kill every fibroid in the uterus. The disadvantage is that new fibroids may form. The uterus is still going to be in place, and they'll shrink about 50%, but they do not disappear. And for some women, if you start with a 14 centimeter fibroid and you shrink the volume 50%, you end up with an 11 centimeter fibroid, which is still very large. Who's a candidate? Any woman with symptomatic fibroids, particularly those who don't want surgery or are poor surgical candidates. And it's helpful if they are no longer desiring fertility. Who's not a candidate? Pregnant women. I've had pregnant women ask me to do embolization. Active infection has to be cleared before it can be done. Endometrial cancer, cervical cancer, leiomyosarc, any kind of cancer in the uterus means it cannot be embolized. It needs to come out. If a patient has had pelvic radiation in the past, that may compromise the collateral blood flow to the uterus. The risk then of uterine infarction is too high, so those women are not a candidate. Renal dysfunction, you can't do this procedure without contrast, and so that can be a problem. It's not always prohibitive. I've treated several women who are on dialysis, which makes that a non-issue, but renal dysfunction can be a problem to be able to have embolization. And if there's a large intraluminal fibroid, they can be problematic because they could slough and try to expel. And if they're too large to expel, it can cause all kinds of problems, including infection and, had patients go into labor trying to pass fibroids. So my key points would be you need meticulous attention to technique to make sure you're not going to have inadvertent embolization of non-target organs. 75% of hysterectomies can be avoided using uterine fibroid embolization, and it's very important to collaborate with your gynecologists to assure that any clinical issues that cannot be managed with interventional radiology will not come as a surprise to the gynecologist, and they will work with you to manage the patients together. And with that, I say thank you, and do you have any questions?
Yeah, we have time for several questions. if you want to get started on there, Spencer.
Yeah, we got a question. So I know there's a lot of controversy over doing UFE for women who want to get pregnant. And I was just wondering what your experience with that was and if you still cover it or how you kind of address that with the patients.
So I have been one of the people who've said, if you want to get pregnant in the future, I'm not doing a UFE in you. That has been my stance. But as more and more data comes out, it looks like the risk is miscarriage. There's the only data available that compares directly. There's lots of data that shows the ability to get pregnant after either a myomectomy or a UFE is very, very similar, about a 70% chance. But the chance of ending up with a live baby is better for myomectomy in the one study that's been done, significantly better. And that study, though, was very, very small. As more data has come out, it looks like the risk of miscarriage is identical to age-matched women who have, so if you have a fibroids and a UFE, your risk of miscarriage is very similar to if you just have fibroids. The UFE does not add significantly to the miscarriage rate. So I have loosened my standards. If I have a young, healthy woman who's trying to get pregnant and fibroids are the issue, I'm willing to do the UFE. I give her all the data. But if I have a woman who's really going to have our time, I see a lot of women in their mid to late 40s who are trying to get pregnant. I usually tell them, go as soon as you can to a fertility specialist, do whatever she says. I guarantee you 100% she's going to say, don't have a UFE. And I would agree with that. If you're going to have a hard time already, I wouldn't add the insult of doing an embolization of the uterus first. So when more data comes out that is positive for UFE, I'll be a strong advocate. But I think the data is emerging as time goes by.
Great, thank you. We have another question in the chat. If you could talk briefly about how you built your clinical practice and whether or not you're part of radiology or if you're independent from DR.
So I'm actually in an independent interventional radiology practice. I started with two other guys who were doing peripheral vascular work and vein work, and I wanted to do fibroid embolization, and they hated the procedure, but I wanted to do that, and they said, okay, they'll support me. So we did a lot to build the practice. We did a lot of marketing directly to patients. We did radio ads, and there were times when if the radio ad didn't play that day, we didn't get any phone calls. But radio ads and then Google AdWords. I talked to churches. I went to I did tremendous outreach in the Black community. And anytime somebody asked me to give a talk, I was there, very active. And also at the same time, marketing heavily to gynecologists. My first year, I got referrals from 6 gynecologists. This year, we got referrals from over 500 gynecologists. So also in the beginning, more than 80% of my patients came to me behind the back of their gynecologist. Every one of them, I said, do you mind if I contact your gynecologist? Every one of them, their gynecologist and their primary care doc got letters from me saying, hey, your patient came to see me. I'll keep you posted of what happens. And I did. I'm very communicative with the patient's primary care providers. And the word spread. People heard. You have to take good care of the patients, though. You can't have bad outcomes, and you can't have the patients calling the gynecologist to say, hey, I'm having pain. You have to take care of the patients. You have to get good reviews, and you have to be available to the patients, and you have to communicate very well with your gynecologists. So, by the way, now probably more than 70% of my patients come from gynecologists and primary care docs. I get a lot from primary care docs, and I get from hematologists, oncologists who are seeing anemic women. I see patients who are getting blood transfusions every month. I do a UFE and they never get a transfusion again.